Medullary carcinoma of the thyroid, MTC. Medullary carcinoma of the thyroid, MTC, is a rare form of thyroid cancer arising from parafollicular cells, C cells, of the thyroid gland. These cells secrete calcitonin, a hormone involved in calcium homeostasis. MTC can occur sporadically or as part of a genetic syndrome. Origin: MTC originates from parafollicular cells, C cells, derived from the neural crest during embryonic development. These cells produce calcitonin, a key biomarker for diagnosis and management, other neuroendocrine markers like carcinoembryonic antigen, CEA, and chromogranin A. Types: MTC can be classified into two main categories. One, sporadic MTC, 70 to 80%, occurs without a family history, usually presents as a unilateral tumor, associated with older age, typically 40 to 60 years. Two, hereditary MTC, 20-30%, caused by germline mutations in the RET proto-oncogene, inherited in an autosomal dominant pattern. Subtypes: multiple endocrine neoplasia type 2A, MEN2A, includes MTC, pheochromocytoma, and hyperparathyroidism. Multiple endocrine neoplasia type 2B, MEN2B, includes MTC, pheochromocytoma, and mucosal neuromas. Familial medullary thyroid carcinoma, FMTC, MTC without other manifestations. Patients with MTC may present with 1. Local symptoms: thyroid nodule, usually painless, firm, and fixed if invasive; hoarseness due to recurrent laryngeal nerve involvement; dysphagia or dyspnea in advanced disease. 2. Hormonal symptoms: diarrhea due to secretion of calcitonin or other peptides, e.g. vasoactive intestinal peptide, VIP, flushing, rare. 3. Metastatic symptoms: cervical lymphadenopathy, common; symptoms of distant metastases, lungs, liver, or bones. 4. Genetic screening and syndromic features: family history of MEN2 or FMTC; associated conditions in MEN syndromes, e.g. pheochromocytoma symptoms; hypertension, palpitations. Diagnosis: 1. Biochemical tests: elevated serum calcitonin levels, sensitive and specific marker; elevated CEA levels, prognostic marker. 2. Genetic testing: RET proto-oncogene mutation analysis for hereditary MTC. 3. Imaging studies: ultrasound of the thyroid detects thyroid nodules and cervical lymphadenopathy; CT MRI for regional or distant metastases. Radioactive iodine scanning is not useful as MTC does not uptake iodine. 4. Histopathology: fine needle aspiration FNA biopsy. Cells show neuroendocrine features. Immunohistochemistry: positive for calcitonin and CEA. Management: management involves a multidisciplinary approach, focusing on early diagnosis and treatment to improve outcomes. 1. Surgical management: total thyroidectomy with central neck dissection, standard treatment; lateral neck dissection if lymph nodes are involved. 2. Monitoring post-surgery: regular monitoring of serum calcitonin and CEA to detect residual or recurrent disease. 3. Targeted therapy for unresectable or metastatic disease: tyrosine kinase inhibitors, TKIs, vandetanib and cabozantinib. These agents target the RET mutation and angiogenesis pathways. 4. Management of metastases: palliative radiation therapy for bone metastases, systemic therapies for progressive disease. 5. Genetic counseling: all patients with MTC should undergo RET mutation testing, prophylactic thyroidectomy for RET-positive carriers based on the mutation's risk profile. 6. Supportive management: address diarrhea and other hormonal symptoms, treat complications like hypocalcemia following surgery. Prognosis: the prognosis of MTC depends on stage at diagnosis. Early stage disease has a good prognosis. Calcitonin doubling time: a short doubling time indicates aggressive disease. Genetic mutation: RET mutations in MEN2B are associated with a poorer prognosis than MEN2A. 5-year survival rates: localized disease, 80 to 90%; regional spread, 70%; distant metastases, 40%. Conclusion: early diagnosis and genetic screening for familial forms play a critical role in managing MTC. Advances in targeted therapies offer hope for patients with advanced or metastatic disease. Regular follow-up with biochemical markers is essential to detect recurrence early.